Good evening, all. We be starting with the Osce surgical Osce, pending when the lecturer for community medicine logs when he logs in, we have to temporarily hold on this lecture. When she completes it, we continue it. I guess that will be okay with you guys. Right? Am I communicating?
Yes, doctor, that's okay.
Okay, so we'll start now. This, like I said, this OSCE is going to be purely an interactive section between you and I. It's not going to be one-sided of whereby I give information. We will attempt the questions, then we'll see how we can answer it together. So who will attempt the first question? Describe this radiograph or describe this image.
Intracranial hemorrhage.
Oh, well, yeah, right in a way. Yeah, okay. What does when you're asked to describe, right? First of all, that's not the question. The question is identify this slide, right? We'll answer that question, but I just added the question, describe this slide, because that can sometimes be an OSCE session. Describe, say, report this CT scan. That can actually be an OSCE session. So if you have to report this image, how will you report it? I'm waiting for a response.
You will start by saying this is a CT scan of so and so person, age so and so, depending on if we are told that information, it has good exposure, and the skull bones are not fractured, but there is a lesion that looks like a bleed, an acute intracranial bleed.
Okay, you tried, you did very well in describing this slide. When instead of saying no fracture, brother, you say these bony structures are normal. That will take away fracture, because sometimes it's not only fracture that you can see depressed bone. So the bony structures are normal. Then the lesion actually is described as a biconvex lesion. A biconvex. If you look at this slide, you see that this is a convex shape. This is another convex shape. On the frontoparietal region of the skull. That's a complete description. So they say describe the slide. Well, as just preliminary which I have said is okay. And it's an axial CT scan of so and so. The age is written there, taken as so and so date, having good exposure. The bony structures are normal. There's a biconvex lesion on the frontoparietal region of the left hemisphere. That's a complete description. Then you say identify this slide. To identify this slide, you said that in this slide there's a biconvex lesion on the frontoparietal region of the left hemisphere of the brain. So what's your diagnosis?
It's an epidural hemorrhage.
I'm not hearing you, please. Come again. I didn't hear you.
It's an epidural hemorrhage.
Yeah. Okay, it's like Dr. Etubi, you are around now. Please, are you ready, Dr. Etubi? Please, Dr. Tubu, if you are ready, kindly let me know, please, so we can allow you to comment the lecture.
Chief,
Yeah.
what? You said at least 5 complications. Complications of this.
Yes.
This is epidural hematoma, isn't it, Chief?
You're right. You're right.
Yes. So, the complications.
Yeah. Attempt it. We'll answer it together.
Oh, okay. And how we want it. I had not joined at the time, please.
Sorry?
Oh, it was answered.
We will not answer it. I said you can attempt it. Where this.
Oh, okay. Okay.
Like I said,
Okay.
it's an interactive section. It's not just a one-way thing to get.
Okay. Okay, Chief.
Shibetu, if you are ready, let me know so I can allow you share your slide, please.
Good evening, sir. Good evening, all. So sorry for joining late.
Let me allow her share a slide. So I will stop sharing right now, right away. Well, let me just finish this particular slide, then I'll allow her continue. So what are the 5 complications? Complications are good. So the diagnosis is it's left frontoparietal epidural hematoma. That's a complete answer. Left frontoparietal epidural hematoma. What are the possible 5 complications from this? With this hematoma, it could compress on the brain structure and force it to herniate down through the foramen magnum, right? So one of the complications would be herniation. That's one of the complications. Another of the complication could be unconsciousness. Another complication could be headaches. Another complication could be seizures. Another complication could be memory loss. Knowing fully well that around this region, that's where you have the hippocampus around this region. Another complication could be motor dysfunction, such as paraparesis, paraplegia. Knowing fully well that the motor cortex around this region. So any compression that will cause pressure on this stuff can actually cause. Since this is left, right, it will cause a right paraparesis. Are we communicating? So I've listed how many complications now? I've listed up about 7 complications.
So, Chief, this is left, not right.
This left. You know, in your CT scan, your right becomes your left becomes your right, right?
Oh, okay.
Yeah, so once your right becomes your left, once your left becomes your right. So how will you treat this? Can someone attempt it?
A borehole?
No. Okay, someone. Sorry? Sorry? I'm not hearing. I can't hear you.
It's craniotomy, sir. I'm sorry, my network is bad. That's it.
Okay, what do you say?
He said craniotomy.
Yeah, that's craniotomy. I'll explain different. There's a different. The answer is craniotomy. Now, in your MCQ, you could see borehole, you could see craniotomy, you could see cranectomy. There are 3 different things. Now, let me explain what these 3 simply means. In borehole, you understand? You drill hole through the skull, right? There's a type of drill, what we call Hudson drills. There are different types. You drill about 3 to 6 holes, and then from that hole you can scoop the blood out, or sometimes the blood will come out from that hole if you scoop it. Now, why borehole is not done? Borehole is done for chronic conditions such as chronic subdural hematoma. Why it's so is that at chronicity, the blood is not as thick. It's like oil. Particularly, let's use what engine oil. You know, new engine oil. It's in that consistency. So if you if you do craniotomy, you can actually drain the blood from. So if you do borehole, rather, you create hole, you actually scoop the blood by from those holes. But in epidural hematoma, commonly what is found there is blood clots. Blood clot will not come out from a borehole. Hence, you do a craniotomy. In craniotomy, what you do is that you open up the skull. So let's say this is the skull. Now you want to do a craniotomy, you have to cut like this off, right? Cut like this off. But then you cut like this off. Again, let me come again. Borehole, you drill like 3 holes. 1 hole here, 1 hole here, perhaps 1 hole here. Once you drill the blood, you can actually drain those altered blood through this hole, because the blood in chronic states is usually altered, not fresh blood. So like I said, the blood is like, if I'm to describe it, I use what, you know, this, I use what engine oil, but the engine oil is not an acceptable term anyway, medical. I'm trying to picture it. I'm trying to give you a picture. Engine oil that you just bought for your car, how it's the consistency, that's how a chronic altered blood in chronic subdural hematoma looks like. Hence, it's easy to just drain holes, tiny holes, and then get the blood, altered blood out. But in epidural hematoma, it's an acute state. So the blood are clotted. So therefore, it becomes very difficult to get out this blood from this place. You need to do a craniotomy. What craniotomy simply means that you excise a chunk of the bone. Let's say, like, for instance, you excise like this part of it. So that gives you great access to this blood, to this altered blood, where you can actually scoop it out. That is the difference between borehole and craniotomy. After doing that, you then apply the bone back. That's a craniotomy. In craniotomy, after excising the scalp bone, you don't return it back immediately. You place it somewhere else. For instance, you can place it in the abdomen. After some time, you can place it back. Craniotomy commonly is done once there's increased intracranial pressure. The essence why you don't return the bone back is that you want to allow for the swelling, for a space where the brain will actually swell into. So once you remove this bone and you take it up, so the brain has a space where it can actually swell to, and then subsequently, when the increased intracranial pressure has dropped, you can then go and replace your bone. You can then go and place your bone back. So in craniotomy, you don't return the bone back. In craniotomy, you return the bone back immediately. In borehole, you don't excise the bone.
Chief. No, Chief.
Yep.
So, for example, in the craniotomy, so there's usually no increase in intracranial pressure.
Sorry?
So that's why in the procedure for craniotomy,
Yep.
right, there's usually no increased intracranial pressure. That's why we're returning the bone immediately.
That's what I'm saying. There can be increased intracranial pressure in craniotomy, but it's not significant that the patient is at risk of coning. Therefore, again, like I said, once there's a bleeding in the brain, you will have increased intracranial pressure. For instance, this bleeding here will cause increased intracranial pressure, right? But if the intracranial pressure is such that the patient is at risk of coning, then it means that if you return that bone back, if you do a craniotomy, that brain will not have space to expand to. So you don't put the bone. So in instances where patients are at risk of coning in conditions of raised intracranial pressure, you do a cranectomy. So cranectomy is not an indication, it's not a surgery for extradural hematoma, it is craniotomy. So you will see the question will come out in MCQ that patient has something like this, they give a clinical picture, and then a biconvex lesion was noted on this on CT scan, what is the treatment of choice? You see cranectomy, you see craniotomy, you see buckle. So in that instance, it's craniotomy you choose. Are we communicating?
Yes. Now.
Okay, so I'm going to end this lecture
Yes, sir.
here for Dr. Mrs. Etubi to continue the lecture.